Welcome everyone to this third day of the National Thrombosis Week with this conference as being hosted by Thrombosis UK. I'm Dr Catherine Bagot. I'm a consultant haematologist at Glasgow Royal Infirmary, and I'm very pleased we've got a lovely set of speakers today to educate you on various aspects of venous thrombosis. I hope you've all had a chance to look and hopefully listen to some of the other talks that have already happened as part of this conference. They're all available at least until the 31st of May, and that's how long we can give you accreditation for watching them. But if we get permission of any speakers to have the talks on the Thrombosis UK website, then they'll be available for longer. There is going to be the opportunity to ask questions. Basically, we're aiming for talks that are about 20 minutes long, and then we'll have 5 minutes of questions. What I'd like you to do is put these questions in the Q&A section or the chat section in your toolbar, and myself and Joe will be keeping an eye on those, and then we'll moderate the questions at the end of the talk. As you probably know from the agenda, there should have been myself and Dr. Julia Anderson here today co-chairing. Unfortunately, due to unforeseen circumstances, Dr. Anderson hasn't been able to attend, but she's played a huge role in bringing together these talks today. So without further ado, and to keep us on time, the first person I'd like to introduce is Dr. Rob Noble, who's a SPR in haematology at the Edinburgh Royal Infirmary, and he's going to be talking to us about splanchnic vein thrombosis. So over to you, Rob.
Okay, thank you very much, Dr. Bagot, and thank you, Dr. Bagot and Joe and Dr. Anderson as well for having me and giving me the opportunity to present today. I hope everyone can see my slides and hear me okay, and I am going to be presenting on splanchnic vein thrombosis. So this is a common call we get in our hemostasis and thrombosis job in the Royal Infirmary of Edinburgh. I thought I would go through a couple of scenarios, very similar cases that we've had in recent times, and the kind of discussions and considerations that are required when dealing with these patients. So just briefly, the first scenario would be a patient in their 70s with an ischemic heart disease and cardiovascular background who presented with severe epigastric pain and vomiting. The CT showed acute cholecystitis, and the right branch of the portal vein was non-opacifying, so suspicious for a portal vein thrombosis. MRCP confirmed the cholecystitis and the thrombus within the portal vein. Coax screen was normal, fibrinogen was raised in keeping with a raised inflammatory response, and the CRP was raised as well. And this patient came through the surgical team with a plan for triple therapy antibiotics and to discuss with the haematology department regarding treatment of the portal vein thrombosis, and that was the telephone call we would receive. So just contrast this with another patient. This time it's someone in their 50s. Presenting with abdominal swelling and found on imaging to have a new pickup of cirrhosis with splenomegaly and ascites. The imaging showed portal vein thrombosis as well as superior mesenteric vein and splenic vein thrombosis with cavernous transformation. Blood results were fairly unremarkable with a normal blood count and normal LFTs, and coag screen unremarkable. And so this patient undergoes a little bit more investigation this time to look for underlying causes. Immunoglobulins normal, no paraprotein. Lupus screen and antiphospholipid antibodies negative. And then an inheritable thrombophilia screen negative with factor V lipoprotein normal levels of antithrombin, protein C and protein S. PNH screen negative, and on the molecular testing for JAK2 V617F mutation, this was detected, even in view of the relatively unremarkable full blood count and no other highly suspicious symptoms. So two patients with splanchnic vein thrombosis, two quite different pictures and stories and management approaches. So what is splanchnic vein thrombosis? Well, it's the name given to any thrombosis within the splanchnic venous system, which drains the GI tract from the lower esophagus to the upper 2/3 of the rectum. This encompasses, as you can see on the picture there, portal vein thrombosis, splenic vein thrombosis, mesenteric vein thrombosis, and Budd-Chiari syndrome. Budd-Chiari is defined as hepatic venous outflow obstruction anywhere between the hepatic venules and the insertion of the IVC into the right atrium. So anywhere in the liver or up the IVC into the right atrium. How often do we see splanchnic vein thrombosis? Well, it's rare. It's relatively common among patients with liver cirrhosis or malignancy, but overall it's at least 25 times less common than usual site venous thromboembolism, although the presentation is often much more dramatic. Portal vein thrombosis is the most common, occurring up to 92% of splanchnic vein thrombosis cases, and Budd-Chiari syndrome is the rarest, which occurs in only a few percent of cases. However, myeloproliferative neoplasms are overrepresented in Budd-Chiari syndrome cases, and MPNs constitute 17% of splanchnic vein thrombosis, and actually cases where you've got idiopathic Budd-Chiari syndrome, up to 62% of those will be found to have a myeloproliferative neoplasm underlying that. In terms of annual incidence, these conditions are rare. So portal vein thrombosis being the most common, up to about 3.8 per 100,000 per year, and Budd-Chiari syndrome much more rare. So what causes these kind of splanchnic vein thrombosis? Well, the most common factor is a local risk factor. So most commonly liver cirrhosis, solid tumor, or pancreatitis. Typically, this is in combination with a transient risk factor of surgery or local inflammation. And among the risk factors, cirrhosis and solid tumors represent at least half of the cases. Unprovoked or idiopathic SVT, splanchnic vein thrombosis, is a large proportion as well. So up to almost a third of cases can be seemingly unprovoked or presenting idiopathically, and actually picked up incidentally on imaging in up to 1/3 of cases. As I've mentioned before, MPNs are common and actually the most common systemic risk factor. So 40% of hepatic vein thromboses and 31% of portal vein thromboses that are not non-malignant, non-cirrhotic patients will be found to be due to a myeloproliferative neoplasm. This slide is just representing the risk factors for splanchnic vein thrombosis, and you can see there's a lot there. It's just worth glancing over. Obviously, you've got the intra-abdominal etiologies of localized problems, infection, inflammation, malignancies, cirrhosis, and then you've got your other conditions that you should think about if you've not got an obvious provoking cause, namely the myeloproliferative neoplasms, thrombophilias potentially, and PNH. And then you've got your autoimmune disorders that are giving you an increased thrombogenicity, and obviously you've got other factors that increase your thrombotic risk, medications, infections, previous history that we would do for any thrombosis patient. So as I've mentioned, local risk factors. So I looked at, okay, how many of these patients developed? Well, in cirrhosis, potentially up to 26% of patients would develop a splanchnic vein thrombosis at some point. And in acute pancreatitis, the studies looking into this, maybe around 12% will actually develop a splanchnic vein thrombosis. And usually it's splenic vein thrombosis for acute pancreatitis patients. It can be a marker of occult malignancy. So 8% of patients with splanchnic vein thrombosis will have a malignancy diagnosis within the 3 months of diagnosis of their splanchnic vein thrombosis, and that's usually liver, pancreas, or, as I've mentioned, MPNs. So what are the systemic risk factors? Well, MPNs mainly, as I've mentioned. Looking at this in a meta-analysis from 2012 in unprovoked splanchnic vein thrombosis, it showed that they looked at 855 idiopathic patients with portal vein thrombosis, and actually 31.5% of those had an underlying MPN diagnosed. Even more than that in Budd-Chiari patients. They looked at over 1,000 Budd-Chiari patients with seemingly unexplained thrombosis, and MPN was found in 40.9% of those, and of those, 80% were JAK2 V617F positive. So a large proportion of MPNs are underlying these thromboses, even if we don't initially see that on anything obvious other than the presentation with the thrombosis. And actually, if you do JAK2 V617F screening in patients with a splanchnic vein thrombosis with normal bloods, you pick up an MPN in around 17% of Budd-Chiari patients and around 15% of other splanchnic vein thrombosis patients. So as you can see, a lot of evidence showing that JAK2 testing in these patients is very worthwhile, and it's worthwhile doing routinely in all of these patients. So how do they present clinically? Well, usually it's a non-specific combination of abdominal pain, GI bleeding, and distension. There's also obviously infective kind of signs or fevers, nausea, vomiting, diarrhea, constipation, and anorexia. But as I've mentioned, a significant proportion are asymptomatic, and these are usually incidentally detected. A study has found that almost 1.7% of abdominal CT scans detected an incidental thrombosis somewhere in the splanchnic venous system. And the presentation depends on where the clot is. So portal vein thrombosis will present either acutely or chronically. Most, as I've said, are associated with cirrhosis. Mesenteric venous thrombosis can be acute, subacute, or chronic, and can present with bowel ischemia symptoms. Splenic venous thrombosis, as I've mentioned, is rare, more seen in pancreatitis, and can present with a triad of splenomegaly, normal liver enzymes, and varices or GI bleeding. So if you've got a patient with splenomegaly and isolated varices and no cirrhosis, then you've got you could be suspicious, is there a splenic vein thrombosis there? Budd-Chiari syndrome can be fulminant, acute, subacute, or chronic, and can classically present with a triad of hepatomegaly, abdominal pain, and ascites. So how do we manage splanchnic vein thrombosis? Well, it's a slightly different treatment goal in these patients. In DVT-PE, unusual site thrombosis, as we know, prevention of embolization and prevention of progression of the thrombosis is the main aim. In splanchnic vein thrombosis, you can consider the main aim as the prevention and the management of the consequences of obstruction of the venous flow. So the studies looking at that, looking into preventing problems related to venous flow obstruction in the splanchnic venous system. And so these issues can be, as I've mentioned, mesenteric ischemia in mesenteric vein thrombosis. They can be fulminant liver failure in Budd-Chiari syndrome, and it can be leading to portal hypertension and varices in thromboses of the splenic vein or of the portal vein. And indeed, actually, if you've got liver transplant candidates, then if they have chronic portal vein thrombosis, you may see an associated increase in morbidity and mortality post-liver transplant in someone who's had a chronic venous obstruction in that area. So how do we manage these patients? Well, when to treat is the question. Which anticoagulants to use is the second question. And then overall, we're thinking in these patients, when does the benefit outweigh the risks of anticoagulation? Bleeding risk is something to consider in these questions. So thinking about that, patients with liver disease, portal hypertension, do they have varices? Do they have thrombocytopenia? Do they have coagulopathy of liver disease? Do they have any issues with that regard? And this obviously is something to take into account in patients with advanced liver disease, and significant coagulopathy makes anticoagulation management decisions tricky, as we know. So the clinician trying to tease out all the information for these cases is left with a lot of questions, and you often have to make a lot of information gathering and then quite prompt decision making if you're trying to give advice to people over the phone, or if you need to go away, look through things and then see the patient before advising. So what evidence can we use to give ourselves a basis of treating these patients? Well, as I've mentioned, the aims of treatment are to prevent the problems of venous obstruction. So it's to prevent thrombus progression, promote the vessel recanalization, and then prevent VTE recurrence. So you're decreasing portal venous pressures, decreasing bowel ischemia times, and then recanalizing ideally and preventing recurrence of these thromboses of whatever cause. And actually, we have now two meta-analyses that have demonstrated this very nicely. So this summary slide is from a meta-analysis by Matteo Candeloro et al. In 2021. They searched the databases for prospective cohorts and randomized controlled clinical trials, which included any patients with SVT, Splanchnic vein thrombosis. And actually, you can see really nicely here the results. So they included over 1,500 patients, and 1,310 of these were treated with anticoagulation. And then for various reasons, 325 of these patients in these cohorts or RCTs were not anticoagulated. They underwent a 2-year follow-up, and actually you can see that this brief summary slide shows that there was significant reductions in major bleeding, in recurrent VTE, and in all-cause mortality. So even though you're anticoagulating, you're actually reducing the major bleeding risk, you're reducing the VTE recurrence risk, and you are reducing the all-cause mortality overall by significant proportions there, with a significant hazard ratio of halving that risk or more. And that's comparing anticoagulation of all sorts compared to no anticoagulation. So really good evidence of the benefit there in anticoagulating these patients in a wide group of patients. The second meta-analysis on the topic by Emmanuel Valeriari et al. Comes from 2021 also, and this is the outcomes of anticoagulant therapy for Splanchnic vein thrombosis in a large number of studies. So there was 3 randomized controlled trials, and they had 7,760 patients, and then there was a number of observational studies as well with around 200 patients. And this is the demonstrating here of the breakdown of patients. So nearly half had liver cirrhosis, about a third had MPNs, and a significant proportion had solid tumors, and then around a quarter were unprovoked. And actually, if you anticoagulate these patients, again, you see significant reduction in risk and in harm when you are anticoagulating this heterogeneous group of patients compared to when you're not. So you're getting more than double the rates of vein recanalization. The thrombosis progression is reduced by more than half. You're reducing the recurrence of thromboses by a proportion. You're reducing major bleeding incidents by a significant amount, and again, reducing overall mortality by a significant amount from 25% to 11%. So really good evidence of why we should be anticoagulating patients in these settings from these sort of retrospective mainly data and meta-analysis, although this was quite a large proportion of patients in randomized controlled trials. So we know if it's a good thing in general to anticoagulate these patients. Which anticoagulant strategies shall we use? Well, the rates of recanalization were looked at, and that was the only thing that was found to vary between the anticoagulation management strategies. So this chart on the right is a subgroup analysis from that Valeriari meta-analysis, and you can see it's differentiating patients by warfarin or vitamin K antagonists, low molecular heparin only, low molecular heparin to 2 vitamin K antagonists, and then DOACs at the bottom here. And you can see the DOACs from the forest plot, that the rates of recanalization, which is all of this chart, the rates of recanalization are sitting really far over in near the 100% range. So you can see, so overall DOACs recanalization rate was found to be slightly higher with the DOACs and also with the low molecular heparins compared to vitamin K antagonists. Otherwise, subgroup analysis looking at thrombosis progression, recurrence of VTEs, major bleeding, and overall mortality didn't find any significant difference between the methods of anticoagulation. They all impacted similarly. So we know that in general, it's a good idea to try and treat these patients. We know that there are lots of different anticoagulation options, and there's perhaps not a huge amount of evidence to guide us on which ones should be used and which not. So in terms of what do the guidelines say? Well, in terms of the JTH, the ISTH guidelines in splanchnic vein thrombosis from 2020, it really breaks down the SVT with cirrhosis or without cirrhosis, or in patients with malignancy, and that's splanchnic vein thromboses. And actually, it does recommend anticoagulation in all of these patients. So at least 3 to 6 months course in all of these cases. And then actually, it does give clinicians a good scope to individualize the patient management and saying, okay, if this patient's got thrombotic progression or risk factors or ongoing significant risk factors, or if it's unprovoked, consider a longer course than just the 3 to 6 months. So it's giving scope really for these patient by patient evaluations, but also guiding us that we should be anticoagulating these patients. And in the chronic cases, there's a little bit more nuance, but it's still a case-by-case evaluation and may well be beneficial for the patient. In Budd-Chiari syndrome, the approach is slightly different in that anticoagulation is one of the mainstays, and there's other management options as well, but indefinite anticoagulation for people with Budd-Chiari syndrome is recommended. And I can talk a bit more about which anticoagulants to use, but again, it's giving you options with or without cirrhosis or patients with cancer. Really, with cirrhosis, it's mainly recommending delta or low molecular heparins before then switch to VKA or DOACs. But actually, you've got a choice of DOACs, VKAs, or low molecular heparin, really, depending on the patient's circumstances with any of these cases. Is this similar to what the Bovino guidelines say from the Journal of Hepatology, the gastroportal hypertension guidelines? Well, yes, it's quite similar. These make a difference in patients with cirrhosis or without cirrhosis with portal vein thrombosis. This is specific to portal vein thrombosis patients or Budd-Chiari. Again, they break it down into recent patients or chronic patients based on the presence of the clot from 6 months. The regimes they allow you to use is low molecular heparins and then switching to VKs or DOACs. And then they say you can consider DOACs up front in patients without cirrhosis. And the duration actually they're recommending is a little bit longer than the ISTH guidelines. So they're recommending at least 6 months in all of these patients, and then longer term therapy based on patient-specific risk factors. Budd-Chiari syndrome being longer term therapy as well. This slide just on Budd-Chiari syndrome, identifying the management options. There is anticoagulation as the mainstay. There's other intervention options as well. And just to make the point that MPNs are reported up to 62% of idiopathic Budd-Chiari syndrome, which is mainly JAK2 mutations, but also can be CALR mutations. And actually, an underlying prothrombotic state is identified in the vast majority of Budd-Chiari patients. So you should also be looking for antiphospholipid syndromes, PNH, other prothrombotic states as well in these patients. So using DOACs in splanchnic vein thrombosis, well, as we've mentioned, there's not a huge amount of evidence to go on really, but what is there evidence to go on? Just going to skip this slide and just quickly mention that there has been 2 randomized controlled trials of DOACs in splanchnic vein thrombosis. One of these by Hanafi et al. In 2019 was actually redacted due to statistical issues, so it didn't publish the full results. But the other one that we can look at is Plessier et al. In 2022, which was a randomized controlled trial which randomized 111 patients with non-cirrhotic chronic portal vein thrombosis 1-to-1 with rivaroxaban 15 milligrams once daily or a placebo. That choice of 15 milligrams once daily was used because of the specifics of dosing of rivaroxaban. So the study authors hypothesized that dose of 15 milligrams which is slightly reduced compared to the 20 milligram daily dose that you give in therapeutic anticoagulation, it might have beneficial effects on reducing portal pressures and having a bit of boost from a first pass metabolism effect, whilst also sort of balancing a high, not too much of a high bleeding risk. So that's why they went for the 15 milligrams daily of rivaroxaban in these patients. And actually, it was against placebo, so the patients randomized to placebo obviously didn't receive anticoagulation, and the primary endpoint was VTE at any site or death within 2 years. Actually, the study was discontinued at 28 months after the second interim analysis because there was found that actually a lot, there was significant, even though patients with major thrombotic risk factors were excluded, the incidence of thrombotic episodes was nearly 20 per 100 in the recurrent venous, in the patients without anticoagulation, so nearly 20 per 100 person years, and it was significant that they stopped this study then, and obviously rivaroxaban was found to be beneficial in the endpoint of VTE and death. This is the waterfall plot just showing that. So you can see patients with non-cirrhotic portal vein thrombosis with no anticoagulation, their thrombosis-free survival significantly drops off over the 2 years. Patients on rivaroxaban, I think overall experienced no thrombosis-free reduction in survival. So quite significant, again, evidence for the use of DOACs and for anticoagulation. So what should we consider in terms of DOACs? Well, hepatic dysfunction, renal insufficiency, and thrombocytopenia obviously caution us. You can't use DOACs in child Q class C liver failure patients, and there's caution in child Q class B, or rivaroxaban you cannot use in child Q class B either. So it's about a case-by-case assessment of these patients. Consider the bleeding risk. Is there contraindications to DOACs, the renal function, the liver function? Do they have luminal GI cancer? Do they have high bleeding risk? And individualize the therapy based on that and the evidence that we have. The BSH guidelines are quite open-ended with that, so they say that DOACs can be considered in these patients, but there isn't enough evidence to express a strong preference to these at the end. ISTH does say that, actually goes slightly further in saying they suggest DOACs in non-cirrhotic patients, and then in the cirrhotic patients with splanchnic vein thrombosis, ISTH actually potentially suggests therapeutic low molecular weight heparin, and then a switch to DOACs or vitamin K antagonists if appropriate for the patients and if not contraindicated. So a little bit more guidance there, but again, giving clinicians scope to use any of our anticoagulant options. Give us a bit more specific in terms of cancer associated as well, which is again low molecular heparins or DOACs, and then in high bleeding risk patients, the ISTH suggests considering individualized dose reduction or delaying treatment or withholding anticoagulation in patients with a very poor prognosis or short-term prognosis, especially if you're worried about extreme bleeding risks. And then duration of therapy, we've mentioned, really is individualized to the patient, but really almost at least 6 months is what the guideline is saying, certainly at least 3 to 6 months for these patients. We mentioned with chronic, again, is more of a case-by-case discussion, but probably can anticoagulate still if appropriate for the patient, and then incidentally detected, you're just treating the same as for a patient presenting with symptoms, and Budd-Chiari syndrome, you are going to anticoagulate indefinitely. So that's kind of a review of the guidelines and everything for these patients. I think, you know, we get quite a lot of these calls, and they can be quite nuanced, and there can be quite a lot of thought that needs to go into them, and then maybe not as much knowledge or appreciation from maybe medical teams or surgical teams that are calling about these patients. So it's good, I think, for hematology teams to be aware and have that latest evidence at the fingertips. So thank you very much for giving me the opportunity to present Dr. Bagot and Dr. Anderson and Joe, and I'll give the opportunity for any questions or discussions now. Thank you.
Okay, thank you very much, Rob. We're running a little bit over time, but thank you. That was a really, really comprehensive talk going over some of the really, really important points about superficial vein thrombosis. So what I'm going to do, Rob, you'll probably see there's quite a lot of questions in the chat, questions in the Q&A section. Maybe during the next talk, you could have a little look at those and see if you can answer them for everyone, just because we haven't really got enough time to take live questions just now. But if you could respond as you're able to all the questions, making sure you respond to everyone, that would be really helpful. Thank you.
Absolutely, thank you.
So if you can stop sharing your slides now, that'd be great. And I'm now going to move on to Dr. Hanan Mustafa. Now, unfortunately, Dr. Hanan Mustafa can't be with us today, again, due to unforeseen circumstances. Dr. Mustafa is a consultant obstetrician based in Edinburgh, and is she's very kindly done a recorded talk for us. And we're just going to set that in motion now. I'm very happy for you to put questions in the chat or the Q&A, and I will try my best to answer them. So Joe, if you could start that for us now, I'd be very grateful.
Sorry, let me just go back.
We have no disclosures.
Right. Let me just go back and start again. Right.
Good morning, I'm Julia Anderson, and I'm really sorry that neither I nor Dr. Hanan Mustafa, my obstetric colleague, can make the meeting today. However, we hope our short presentation will be of interest and follows our theme of obstetric conundrums that we've presented at previous Scottish Thrombosis UK meetings. We have no disclosures. We work at Simpson Centre for Reproductive Health. This slide shows James Young Simpson, a pioneer of chloroform anaesthesia and alleviation of pain in childbirth. Simpson's Hospital was located in two parts of Edinburgh before relocating to its present site at Little France, shown here on the right-hand side of the slide. The importance of close collaborative teamwork is essential for successful outcome, shown by our clinic team here of midwives, specialist nurses, administration and clerical support, specialist hematology laboratory support, anaesthetists, paediatricians, obstetricians and hematologists, as well as, very importantly, training colleagues for the future. Our talk today focuses on superficial thrombophlebitis to highlight the paucity of evidence to support best practice and conundrums and dilemmas that the clinician faces. Superficial thrombophlebitis has largely been considered a benign, self-limiting, localized condition, probably caused by local blood vessel inflammation and blood hypercoagulability. We know that superficial thrombophlebitis is diagnosed more commonly in our same-day emergency care units than DVT or PE, and it has heterogeneous causality. Broadly speaking, categorization can be those cases related to varicose veins, sometimes called varicophlebitis, where there is a sterile inflammation of the blood vessel wall, and situations where varicose veins are not existent. We know that if left untreated, superficial thrombophlebitis may cause DVT and pulmonary embolism in around 10% of patients within the first 3 months of diagnosis. We also know that asymptomatic DVT is found in about 18% of patients with superficial phlebitis, indicating it may represent clinical manifestation of thromboembolic disease. We tend to prescribe a short course up to 45 days of anticoagulation in patients with superficial thrombophlebitis with high-risk features, and that sometimes relates to the length of the phlebitis. Patients with isolated superficial thrombophlebitis within 3 centimeters of the saphenofemoral or saphenopopliteal junction are usually prescribed 3 months of anticoagulation to prevent DVT. So what do we know about superficial thrombophlebitis in pregnancy? Well, it seems to be quite a frequent problem. I see it a lot in our clinic, and it's impactful and affects women during pregnancy. But with a paucity of evidence to inform us about best practice. There is very little high-quality data on the course of pregnancy-associated superficial thrombophlebitis and no population-based treatment studies. So guidance is largely based on the extrapolation of data from general studies to the pregnant population. So for example, the conditional recommendation to use low molecular weight heparin in pregnant people diagnosed with superficial thrombophlebitis is made in the American Society of Hematology 2018 guidance. And position papers from other regions of the world are being published. This slide tries to show risk factors for pregnancy-associated superficial thrombophlebitis. And I placed the star by the main ones that are commonly found in pregnancy. So varicose veins are very common. Patients will have a personal or family history of venous thrombosis. They may have been screened for thrombophilia in the past and found to be positive. They may be overweight and they may have been immobile for any number of reasons. And we know that pregnancy causes a hypercoagulable state, in part due to the increase in coagulation factors, like factor VIII, von Willebrand factor activity levels from an early point in pregnancy, coupled to the reduction of natural anticoagulants like protein C and protein S, increasing compression of the pelvic veins by the gravid uterus in later pregnancy, and also inhibition of fibrinolysis. Last year, results from a Danish nationwide cohort study were published evaluating the incidence and prognosis of superficial vein thrombosis during pregnancy and the puerperium. The study aims to evaluate two things. Firstly, the incidence of lower extremity superficial thrombophlebitis up to 12 weeks postpartum. And secondly, the risk of subsequent venous thromboembolism in the same pregnancy or postpartum period. The study followed a large cohort of women, retrospectively over 1.2 million pregnancies in 733,000 women. And the demographics show typical features for women at our clinic, maternal age, gestational age, and pre-pregnancy BMI being shown in this slide. The results indicated that 710 women were diagnosed with superficial thrombophlebitis from the time of conception up to 12 weeks postnatally. So this equates to 0.6 per 1,000 person years. And that statistic's consistent with other reports in the literature. Of 211 women with the antepartum superficial phlebitis included in the analysis, 10.4% of those women, 22 of them, with antepartum superficial phlebitis went on to be diagnosed with venous thromboembolism, and this corresponded to a cumulative incidence of 13%. But as this was a retrospective study, the authors could not evaluate clinical, radiological, or laboratory risk factors for venous thromboembolism. The study highlights the low incidence of superficial phlebitis in pregnancy, but the importance of this diagnosis in pregnancy as it holds the potential for adverse venous thromboembolic outcomes if not treated. So there remain many unanswered questions. Which subsets of pregnant women will benefit from low molecular weight heparin? What would be the dose of low molecular weight heparin in superficial phlebitis and the duration? And what should we do in a future pregnancy in terms of antenatal and postpartum thromboprophylaxis? And what to advise women about oral contraception and perimenopausal hormone replacement therapy? So if we move on now to our case, we describe some of the dilemmas throughout the case. This was a 33-year-old lady in her second pregnancy who at 11 weeks gestation presented to our same-day emergency care unit with a tender red swollen right leg. She has a known family history of DVT affecting her father, and previous screening confirms that she's heterozygous for the factor V Leiden gene mutation. She has a booking weight of 108 kilograms. And she has extensive bilateral varicose veins. These issues had been noted when she booked with her midwife, and a decision had been made to start weight-based thromboprophylaxis at 28 weeks gestation. Doppler ultrasound confirmed objectively that there was no evidence of deep vein thrombosis, with compressibility of the common femoral vein, superficial femoral vein, and popliteal vein, but did confirm 25 centimetre length of thrombophlebitis from the anterior calf vein stretching up to the distal left thigh, and with no proximity to the deep venous system. So initially, the treatment was discussed with the obstetric team on call, who advised therapeutic low molecular weight heparin, and the patient was commenced on dalteparin, 10,000 units, subcut twice daily, for what was described as a 4 to 6 week duration. The obstetric team referred her on to our team in the haematology obstetric clinic. And meanwhile, the same day emergency team arranged a 1 week telephone follow-up call. And this was very helpful because it established the treatment was helping and the patient's leg was less swollen and less painful. We were able to fit this patient into our clinic 2 weeks after the diagnosis when she was 13 weeks gestation. And we decided to switch her to once daily dalteparin for ease of administration. And we tend not to do any monitoring of levels. There's a very palpable rod of thrombus, and we plan to treat her for at least 3 months due to the extent of the phlebitis, and then maybe consider reducing to a prophylactic dose in the lead up to term. She was referred to the anaesthetic team because she's now on therapeutic dalteparin, and she was referred for the fitting and measurement of maternity compression tights. We went on to review her at 22 plus 4 weeks. At the clinic, the phlebitis had very much settled, but with the raised body mass index, family history, and presence of varicosities, we were concerned that if we reduced her at this stage to a prophylactic dose of dalteparin, that she may have a flare-up. So we decided on clinical grounds to continue her on a therapeutic dose of dalteparin. We did fit her with maternity tights after ABPI measurements were done in our specialist thrombosis nurse clinic. We reviewed her again at 35 and a bit weeks gestation when she's heading up to making the final plans for delivery. She's developed iron deficiency that's being treated with iron supplementation and gestational diabetes. So there are other issues in this lady's antenatal care. Her leg was examined, and this was the first point where we could not feel any palpable rod of thrombus. So a decision was made to reduce the dose of low molecular heparin to a prophylactic dose from 37 weeks onwards. This is mainly so that we can enable the lady to have a 12-hour rule for the siting of neuraxial analgesia and anesthesia, as opposed to a 24-hour rule. But it's not very easy, we feel, to make decisions about the dose post-delivery. We had decided to restart the prophylactic dose and review her a week postpartum for further decision-making. So at the postnatal review, it was lovely to hear that there'd been an uncomplicated spontaneous vaginal delivery at 39 plus 1 weeks with minimal blood loss. A 12-hour rule had been in place and there had been no complications. We reviewed her and continued her on prophylactic dalteparin and review at 6 weeks. Her varicose veins were still a little achy. There was no actual phlebitis, so we have referred her on to a vascular surgeon for opinion regarding more definitive surgical treatment. But in view of the ongoing ache, we've continued her dalteparin at a prophylactic dose and will continue to follow her up in around 6 weeks' time. So just to recap with our approach, we treat superficial thrombophlebitis during pregnancy with low molecular heparin and not with non-steroidal anti-inflammatory drugs or antibiotics. We treat for the duration of the pregnancy and 6 weeks postnatally, as we believe the thrombotic risk continues over that period of time and for up to 3 months post-delivery if the patient's still symptomatic. We diagnose superficial phlebitis using Doppler ultrasound, and we have had our radiologists uniformly reporting the extent of the phlebitis in centimetres as well as the proximity to the saphenofemoral and saphenopopliteal junction for a good number of years now. We do not repeat the Doppler studies unless the phlebitis worsens or recurs, but we evaluate the patient clinically at our clinic for the response to treatment. And we use low molecular weight heparin, and dalteparin is our brand of choice on formulary as our first-line treatment due to the more complex pharmacokinetics of fondaparinux, and we would use fondaparinux as a second-line treatment in the event of an allergy to low molecular weight heparin. For localized superficial thrombophlebitis that would be less than 5 centimeters in length, we might use a weight-based prophylactic dose of low molecular heparin with very careful follow-up, often a week after clinic. And if there was a poor response or symptoms were worsening, we would escalate the dose of low molecular heparin to a therapeutic once daily dose, again with close follow-up. We'd measure and fit for graduated compression stockings or below knee stockings, and that kind of depends on patient preference and the location of the phlebitis. And as mentioned, we'd continue the low molecular heparin for the rest of the antepartum course, where there'd be a 12-hour rule for citing of regional analgesia and anesthesia if a prophylactic dose of low molecular heparin is used, and there's a 24-hour rule if a therapeutic dose of low molecular heparin is used. We tend to review around 36 weeks if using a therapeutic dose, just to see if we can reduce that dose to a prophylactic one in the lead up to delivery. If we have a much more extensive superficial phlebitis that's close to a saphenofemoral or saphenopopliteal junction, or it's just extensive in length, we will treat with therapeutic low molecular heparin. We don't measure the levels, and we use the current weight to guide dosing. Exceptions to monitoring would be extremes of body weight, renal insufficiency, but we use once daily low molecular heparin on the whole. We're quite pragmatic about the dose, using the manufacturer's pre-filled syringes, mainly to aid compliance and for ease of administration. If treated for more than 12 weeks, we review clinically, and we, as mentioned, try to consider dose reduction to a prophylactic level. But if there's any active phlebitis, there's itch, erythema, or discomfort, or if there's a continuing palpable rod of thrombus or visually impressive varicosities, we count these as ongoing risk factors, and it pushes us really to continue the therapeutic low molecular weight heparin. Depending on the situation, we restart prophylactic low molecular heparin 4 to 6 hours post-delivery. That's obviously is dependent on hemostasis. The rate of re-escalation of anticoagulation after that depends very individually on the mode of delivery and how the patient's doing. But we tend to escalate the low molecular heparin in a stepwise fashion over around 5 to 7 days post-vaginal delivery. And we advise the patient of the increased risk of postpartum hemorrhage. All patients are reviewed at 6 weeks postnatally when we make a decision about discontinuing anticoagulation or continuing for a further 6 weeks if symptomatic. We're tending now to refer patients with impressive varicosities to our vascular surgery service for review. We have a vascular surgeon with a particular interest in venous disease, so this is very helpful, but mainly because we want a specialist opinion prior to another pregnancy, and we don't perform heritable or required thrombophilia testing. In a future pregnancy, we would suggest antenatal thromboprophylaxis to prevent recurrent superficial thrombophlebitis because we feel the chance of reoccurrence is high, and we encourage early application of appropriately fitted Class 2 graduated compression stockings. So in summary, the incidence of superficial thrombophlebitis in pregnancy has been confirmed to be low. Recent evidence highlights the potential for adverse thromboembolic outcomes if superficial phlebitis is not treated adequately. We still don't know enough about the different subgroups during pregnancy that are likely to exist, and the dose of low molecular heparin to use and the duration to treat with. Position papers are being written for various regions, but the advice differs regionally, and that's because of the paucity of evidence. So we do need to do more research in this area. So we're sorry we cannot answer any questions specifically today. We hope that there might be some discussion chaired by Dr. Bagot, but thank you very much for your attention, and thank you to Thrombosis UK for inviting us to contribute to today's meeting.
Well, I'm saying thank you, unfortunately, to with Julia and Hannah not being here, but I just want to say thank you to them. And maybe they'll get a chance to listen to our discussion. We don't have a huge amount of time. I've been keeping an eye on the questions. I think the massive take-home message for me, which I was surprised about, is that the risk of the incidence of superficial vein thrombosis is not actually that high in pregnant women. You know, we know the rate of venous thrombosis, deep vein thrombosis in pregnant women is around one in 1,000. And here we can see the rate of superficial vein thrombosis in pregnant women in that retrospective study was 0.6 per 1,000. So you know, not as high as I would have anticipated. I just wanted to clarify, I'm worried if there are any GPs listening to this, they're thinking, oh my God, I need to be scanning everyone that I see with superficial vein thrombosis. I'd direct you to our NHS GGC right decision platform guidelines, where we do outline what we do, not for pregnancy, but for superficial vein thrombosis generally, is that if you're seeing your general SVTs in the community, unless you think they're very high risk, they're very large, then you don't have to refer them all for scanning, just to be clear about that. One thing that has been pointed out in the chat to me is that during the presentation, when the presenters were discussing the deep vein system, they mentioned the superficial femoral vein. All of us hate the name of this vein because it implies that it's a superficial vein when it is not. So just as a point of reference for everyone, the superficial femoral vein is a deep vein and not a superficial vein. Finally, one other question in the chat, which just wanted to make sure that I hope I've understood it. Someone has mentioned, what about thrombosis due to intravenous line? Now, I presume they're meaning, okay, what if you've got a cannula in a superficial vein? I presume this is what this is referring to. Again, if it's just a very, and all the evidence about, just to go back, all the evidence about using low molecular weight heparin, which is actually quite good when the the superficial vein thrombosis is greater than 5 centimeters, it's very, very clear that you really gain some benefits from using prophylactic dose low molecular heparin, or outside the pregnant population, prophylactic dose rivaroxaban. But what do you do about upper limb superficial vein thrombosis? Well, if you've got a really small one due to an intravenous line, I would not be recommending, my personal opinion, I would not be recommending treating that. But if you have someone who's had, say, a cannula in their antecubital fossa, and it's really extensive, then I think it would be acceptable to extrapolate what we know from managing lower limb superficial vein thrombosis to the upper limb. And I'll just look at one more question. Was hemophilia screening mentioned in the case of pregnancy-associated STP? They mentioned that they don't do it, and I would certainly concur with that. So yes, I wouldn't be recommending thrombophilia screening. So in the interest of time, we're doing well, but we're just 2 minutes over. I'm now going to move on to the next speaker, and I have great pleasure in introducing Dr. Colum O'Hare. He's a consultant interventional and diagnostic radiologist at the Royal Infirmary of Edinburgh, and also in the Borders. He's got a lot of interest in peripheral artery disease, interventions in venous disease, and in trauma. And what he's going to discuss today, which I think is going to be really, really interesting, is the role of inferior vena cava filters, putting them in, bringing them out, and when they should be used. Colum, if you would like to share your slides with us. And we can see your slides, that's great. All they need now is to go on to slideshow, and we're absolutely great to go. So the slides are showing, they're not on slideshow view yet. And I haven't heard your voice yet, Colin, but you may not have been saying anything.
I'm looking, you on mute. In your toolbar, you should, yeah, they're on full.
Right. So we've now got the full screen, and Colin, you just need to come off mute and we're good to go. You're off mute, but we can't hear
Sorry,
you.
can no.
Yeah, perfect. That's lovely. Go forth and do.
Sorry, I'm using a combination of a desktop and a laptop to do this. So I think there's firewall issues in the hospital. So yeah, so everyone can see and hear okay, is that right?
Yes.
Yeah, perfect. So yeah, sorry, as you say, I'm Colum O'Hare. I'm one of the interventional radiologists, and I work cross-site doing both interventional and diagnostic radiology between the Royal Infirmary of Edinburgh and the Borders General Hospital. And I was just asked to cover IVC filters, sort of indications, technical considerations and complications or considerations whenever we're actually doing the procedure. So that's essentially just what I'll run through here now. So with regard to IVC filters, their main indication is to act as a mechanical barrier whenever there's low IVC or DVT in situ, and if there is going to be some sort of insult that will provoke the clot to become mobile, or if there's evidence that the clot may actually already be mobile, we're basically just putting in a physical barrier to prevent it from moving and causing pulmonary embolism. IVC filters are used in adjunct to medical therapies, and either if they're contraindicated or if medication or therapies that they're on already aren't actually adequate to help treat the known thrombus. And it should be considered as part of the greater hematology plan whenever being considered or when it's being referred to the interventional radiology team. We do occasionally get referrals from in-house teams who've just asked for it because they think it's needed, but there's a lot more to it than just, as I'm sure everybody in this forum will know, than just putting in a filter and taking it out whenever they've had their surgery. So it shouldn't be referred in isolation, and we usually would ask for, if the interventionist is the first point of contact, we'd usually ask for the hematologist input, and as has already been demonstrated this morning, the hematology team are heavily dependent on locally to help guide sort of the greater hematology management, and we're often referred to by the hematology team to say yes or no whether an IVC filter is required. Obviously, trauma is a big indication or a big discussion point as to whether filters are needed, but we also need the intensive care team, the interventional radiology team, and I've put in plus minus the vascular surgical team, as they will often need to help deal with complications of IVC filters. So it is for us, and I think I could speak for the rest of my colleagues, is that it's a relatively easy procedure to do. But that in itself, sorry, shouldn't be an indication to refer for it. And as I say, we need to consider the bigger picture for the patient. So this next point in trauma, the IVC filter should be inserted as soon as possible. I've just caveated that, which I'll address later on in the presentation. And in non-trauma, as I've already said, warrants MDT input. Important to have an idea as to when the patient may be able to have the IVC filter taken out. Most of the filters do have an advised sort of indwelling duration, at which point removal should be considered. But essentially, the underlying principle is as soon as the patient has adequate anticoagulation, that the filter should be taken out. And either during the same admission or as a planned outpatient procedure, and it shouldn't remain in longer than it should need to. So in trauma, the general principle is that should be inserted as soon as possible, and it's particularly high risk in complex pelvic fractures and long bone fractures. Immobility is seen as a risk factor, but in itself is an indication to actually cite an IVC filter. Obviously, anticoagulation is contraindicated in the early stages of trauma, which is why there is that sort of higher volume of requests in the context of trauma or long bone fractures. And just the principle of Virchow's triad is basically the summation of causation underlying formation of thrombus, especially within the pelvic veins. And as we'll touch on later, just in the NICE guidelines, in non-traumatic VTE, it's indicated in patients who have PE who cannot have therapeutic anticoagulation or who are on anticoagulation and it's not suffice. And I've also put in here prior to surgery and high risk cases. So whenever you read the literature, these are defined as provoking events. And again, we'll touch on that a wee bit later on. So this is just a slide. This is taken from a recent presentation at the NIOR conference in Europe. But it's quite well known, this sort of table. And this is all recent evidence from 2014 up until last year. And a combination of RCTs, retrospective cohort studies, and meta-analyses. The conclusions, as with some of the other discussions this morning, there is no real strong evidence one way or the other, and the overall quality of the data is pretty low. But if you look at the conclusion column here, you can see that there is a moderate risk reduction in fatal PE in observational studies, but not in RCTs. Then there's also this next one, there's increased risk of DVT, no reduction in survival or mortality, equal risk of having further DVTs. This study here is the only one that actually reflects the sort of positive impact that IVC filters have, as it does reduce symptomatic and fatal PEs in the presence of DVT in long bone fractures in the acute setting. So that this is quite a heavily weighted study, but again, is seen as sort of relatively low quality. High risk of DVT, again, no improvement in outcome and mixed results. So it is a mixed bag when it comes to currently available data. And as you can see here, this is just another principle in trauma is immortal bias. Is if a patient's so unwell because of their traumatic insult, they're usually not deemed fit enough to have an IVC filter put in, or that they're sort of going down the palliation route. Whereas if someone actually is well enough, they'll proceed to having an IVC filter, and therefore their outcomes seem better. But it's sort of, you have to question sort of the baseline of the patient at that point in time. Then a non-traumatic VTE, again, relatively low quality data, and again, no reduction in mortality, but it does decrease the occurrence of PEs, and a reduction in subsequent PE, but with increased risk of DVT. Overall mortality is unchanged, and again, limited or low quality of evidence in this context. And again, just to contradict that sort of study that had a relatively strong outcome in it, that would support the use of IVC filter, this is a study that was taken from the United States, over 120,000 patients, using state database study, with patients who received IVC filters in the context of PE or DVT. And this is a study, it is again relatively low quality but high volume patients numbers, and their conclusion was that IVC filter placement in patients with venous thromboembolic disease and a contraindication anticoagulation was associated with an increased risk of 30-day mortality. So not to go into that study itself anymore, but it's these last three slides just to highlight the sort of relatively poor quality of the data and the relative conflict between different types of studies as to what sort of the indication is whenever we're being referred an IVC filter placement. So NICE guidelines have concluded, I'm sure everybody in this forum will be aware of this, but the NICE guidelines have constructed their own guidance on when to appropriately cite IVC filters, and just the first 3 points. So people with VTE who cannot take anticoagulation, as we've already mentioned, but again, low quality data. People with VTE who have a PE while on anticoagulation, so that's deemed that the treatment that they're on isn't suffice to actually treat the underlying embolism or embolic source. But again, low quality data. And then people who have DVT who require a filter or a provoking event. So that is in the context of surgery, orthopedic surgery and long bone fractures. And then another question in that context is patients on anticoagulation that are already established on anticoagulation for a prior pulmonary embolus or DVT at the time of surgery. So if someone's had treatment for a PE 4 months ago and are on apixaban, should these patients actually have a filter placed whilst they come off their anticoagulation to facilitate surgery, to then go back onto their anticoagulation, have a filter removed. So just again, conflicting between two separate bodies, the SIR and NICE. SIR actually advise against this in the absence of an actual proven DVT at the time of surgery, and NICE have sort of sat on the fence and said just advise discussion case by case. And then IVC filters are generally not indicated in cancer patients or recurrent PEs. And in that context, it's a patient who's previously been treated and come off their treatment dose and then had another spontaneous PE at some point down the line when not an anticoagulation. So IVC filters and trauma, we've already sort of touched on this, proven ilofemoral DVT, when a low molecular weight can't be given, complex pelvic fractures. As I've touched on, the SIR don't recommend IVC filter in the absence of a thrombus. And previously it was considered to be indicated in immobility injury with a low GCS. So I think the level they previously went off was a GCS of 6 or below. But again, they are contributing risk factors, but they themselves are not actual indications to proceed with IVC filter placement. This is just a summary of recommendations from SIR. And again, this is just, it's got a lot of detail. It looks quite busy, but I've just highlighted the strength of the recommendation in each point or recommendation. And you'll see that there's very little evidence to suggest that those recommendations are actually there's no strong consensus really as to IVC filters within each of those contexts. So again, it's a very mixed bag. Nobody can say with certainty one way or another because of all the conflict within the data that's available. But locally, we just use the NICE guidelines. And as I say, we heavily depend, as an IOR team, we heavily depend on the local hematology team to guide us in that context. So IVC filter removal. So the removal should be as soon as possible, as I've already said. The patient that has the IVC filter, the filter itself is a foreign body. It'll be prothrombotic. So the patient will need covered with some form of anticoagulation until the point that the filter has come out. It can be done in the same admission or planned for future removal. Again, a discussion point in a lot of these IOR presentations, a patient who does actually have head and neck trauma, we need access from the neck to actually be able to retrieve these. So in that context, planning for a delayed removal within months of discharge, once the patient has sort of regained some sort of normal function with their neck, is usually a point in time when we would proceed with taking them out. Yes, will require low molecular weight heparin whilst that's in situ. Just with retained IVC filters, we often see this. I think the number is 60% of IVC filters that are placed do not actually get removed. And that's often due to the complexity of the patient that we actually put them into. But there is no increased P risk, but there is an increased risk of DVT below the level of the filter. So again, it's advantageous to take them out at the earliest possible opportunity. So technical considerations, the device that we use is called the Cook Select filter. It's actually got two separate delivery devices that come in the one pack. You can either deliver it from the neck or from the groin. And the reason you have to use different catheters is because of the hook or where it attaches on to the device. So you actually have to mount the device differently for each of the approaches. We always need some form of imaging beforehand to give us variant anatomy. I've just listed on the left-hand side of the screen the different variants of anatomy. Some of these would actually indicate consideration for suprarenal IVC placement, which is extremely rare. It's actually quite complex and can be a lot more dangerous for the patient, and I have a case of that later in the presentation. Other things we consider are vessel diameter, landing zone, and again that incorporates variant anatomy. And the suprarenal IVCs are generally placed if there's IVC thrombus, IVC compression, and I've put in question mark pregnancy because some of the presentations and literature that's out there does describe putting ASV or putting filters in the suprarenal IVC. However, pregnancy itself is a relative contraindication based on the IFU per filter manufacturers. So again, that would, if that was thrown at us clinically, we would certainly want to question that quite heavily. So in terms of consent and the risk of the procedure, we always consent for progression or worsening of thrombus related to the IVC and the area below the filter. Hematoma and bleeding, but again, that's not an immediate risk. They're usually prothrombotic, and or because we're doing venous punctures, it just requires pressure hemostasis. We rarely need to use stitches or anything like that to get control of bleeding at a puncture site. Filter migration or misplacement, recurrence of P or DVT despite anticoagulation, filter blockage, which would prompt or provoke further pelvic or limb DVT, and then generic complications that can always happen with any procedure: infection, bleeding, pain, failure, and then we've got filter retention as well, so failure to actually remove the filter. This is just a slide showing numerous different types of filter. As I say, we generally use the Cook Select filter, which is this one that I've circled, and most people would probably recognize that if they saw it on an abdominal x-ray as the sort of typical IVC filter. We usually like to have some form of formal imaging beforehand. We usually have a CT scan of some sort. Usually the patients that warrant an IVC filter will have some sort of investigation cross-sectionally, and we always use that to basically get our landmarks. We want to know where the renal veins are, the iliac veins are, and any accessory veins. And when we're doing our procedure, we actually use the bony landmarks as well to help guide us in our placement. So this is just an image taken during a procedure. The yellow arrows are actually pointing at the renal vein origins. And if you can believe me here, there's a bit of narrowing just within the main lumen, and that's where they're actually getting the jets of venous blood from the renal veins that sort of give a dilution effect at the level of entry. And just behind the arrow on the left, we use the bony landmarks of the vertebral bodies and the disc spaces to actually act as landmarkers whenever we go to place the IVC filter. So as you can see, the image on the left here, we don't actually have anatomy or detail of the vein, but we can confidently use the disc space or the vertebral body to help us land this. So typical insertion, as I say, if this was me doing it, I would put my crosshairs on the lowest renal vein origin and then just scroll backwards and see what the nearest bony landmark is. So in this case, it's sort of the lower edge of this vertebral body and the disc space. Again, we do a venogram, find the lowest renal vein which corresponds with the CT, and again, just find the disc space that corresponds to. And now I know I'd be in a safe area to deploy this below the renal veins using this bony landmark, which is what we've done. This is a recent case where we put in a filter. This is the disc space that we're using as reference, and it thankfully didn't migrate and stayed where it needed to be. So typical retrieval in a similar fashion, done from the neck. As you'll see, this was me putting in the filter from the groin. This is the head side of the patient. This is the pelvis side of the patient. And I'm just coming in from the right groin and deploying this. The retrievals are typically done from the neck, and that's to do with the configuration of the filter itself. So there's a hook at the top of the filter, and all we do is you use a device called a snare. These are quite commonly used across all our specialties as well. And it basically lassos around the hook of the filter, and we can then grab onto it and then slide our sheath down over the top of it. It's important to say, just from a technical point of view, we don't want to, once we've lassoed this, we don't want to drag the filter up. The wee feet that are on the filter are actually hooked, and that's what embeds and engages them within the IVC wall. So where it's all possible, we basically take the sheath down to the filter, and that allows it to collapse and allows all the limbs to get taken into the sheath, and then we can safely remove it. So just I've got a couple of cases. I've probably only got 7 or 8 minutes left, so I will try and go through the couple that I have. So this was an 80-year-old female who had an IVC filter placed 18 months ago overseas. She does have a history of retroperitoneal fibrosis, prior surgery for abdominal aortic aneurysm and also for colorectal cancer, has had surgical resections and has bilateral nephrostomies due to her retroperitoneal fibrosis. And the indication for trying to remove the filter was she was having hematuria. So this is just a CT scan which shows the 4 legs of the IVC filter. This is a scan. This is the front of her tummy. This is her back. This is her spinal bone. This is her aorta here, and these are the 4 struts, the 4 larger struts on the filter. This picture I've tried just this yellow circle here is actually the outline of the IVC, and we can see that 2 of the struts are actually quite definitely out with the IVC, and we do see cases where these can actually embed within the lumen of the aorta. So we knew this was going to be a tricky case, so we actually tried to retrieve this on an instance using just standard snare technique, as I showed you previously. However, it was so difficult to remove. The patient started getting agitated. We had to stop and abandon on the first occasion and bring her back for a second attempt. So this is a technique. It's just known as the hangman technique, where basically we try to overshoot the stent with a catheter, and then we snare a wire. So we create a loop with a wire, and that just allows us to try and get more control and actually put a lot more force through the.
We've lost your sound, Colum.
Which we didn't fully appreciate at the time. Oh, hello.
We lost your sound very briefly for about 5
Oh, sorry.
seconds.
Oh,
It's
sorry.
okay,
Sorry.
you're back now. You're back now.
Sorry.
Carry on.
That's fine. So the wire here is just slightly kinked, so we didn't fully appreciate that at the time. And I just urge you just to focus on this bit here and the bit like sort of like a comma shape. But then as we try to draw in the filter to the sheath, we then see that it's actually separated and it's now lying alongside the sheath. And these are real-time images. So we see it going from here, going further northward, and then it literally goes off the screen. So this is just to highlight, one, just the technique that we can use where we try and wrap a wire around it rather than using the standard snare around the hook, but also a complication of the procedure. Now, I hadn't actually seen this complication before, where the wire actually snaps, but this is often seen if one of the filter limbs snaps. So this is us taking an x-ray of the chest afterwards, which generally is extremely heart sinking. You see your foreign body here, which is a bit of our wire that we use, sitting projected over the heart. This is the spine, a different x-ray, and we've taken this as a lateral, and we've proven that it's in the anterior chest, so it's definitely within a chamber of the heart. And we waited 5 or 10 minutes, and then we can see it now at the level of the pulmonary artery. So we did get the cardiologist in at this point just to review whenever the wire was sitting in the ventricle, if there's anything they could offer a retrieve. And then with time, this actually just went more and more peripherally, and we accepted that it wouldn't actually cause any significant compromise to the patient's hemodynamics. So we brought her back to reattempt the filter retrieval, trying to use a bigger sheath, a bit more sort of robust kit as well. And unfortunately, this is just to demonstrate the amount of force that we actually had to put through the stent to try and retrieve it. And every time we put some force on it, the sheath would bend, and these struts, the 2 posterior struts, remained fixed. So we theorized that these were probably embedded and sort of involved in the retroperitoneal fibrosis process, and therefore we accepted that this is a stent that we wouldn't be able to retrieve. And I will touch in a couple of minutes just on a possible other bit of kit that could be used for that, but that we don't have readily available to us locally. So a case 2, this is another.
Colum, sorry to interrupt you. We're running a bit over time.
Okay.
But there's quite a lot of interesting questions.
Oh, okay.
So I'm so sorry to have to cut you off.
No problem.
It's absolutely fascinating.
No problem.
But would you mind if I stop you there and ask
of course.
all the questions that we've got in? Thank you so
much.
No
worries.
From a hematologist point of view, that was absolutely fascinating. Fascinating.
I have to reinforce that we heavily depend on the hematology team here. So yeah, thanks for that, because
thank you.
Yeah.
So questions. So what's your opinion about, you've said all the time, want to get it out as soon as possible, the filter, put it in. When do you think it becomes more difficult?
So usually, again, we just go by the IFU. So usually, if it's within a year of the patient having it in, we'd usually more than happily attempt that, because that is sort of the accepted time frame for that. Now, in that case, that was a lady who had it at 18 months. I think it's, if there's a clinical indication for it, we rarely would get asked without there being reasonable clinical need for removal of it. And in this case, it was because the lady was having a bleeding complication, but needed to be on the anticoagulation for the IVC. So I think irrespective of time, it's always worth considering and attempting. However, whenever we put it in, we will be on the phone as soon as it's in to see what the plan is and how it can come out. So there is no fixed time, if I'm being honest, and it is always worth trying to remove. But I think you should be aware of the limitation or the increase in complexities with time, that you leave it in dwelling.
And basically before a year thinking, okay, we've got a good chance it's coming out, but after a year, like, you know, okay, that's really helpful. There's another question about, you know, this concern that, okay, we've put this person on, we've put this patient, we've got a filter into this person because we can't use anticoagulation. Haven't we got a big concern that therefore, if the filter's in place, we're just going to get massive deep vein thromboses if we're not going to be anticoagulating them, which is the reason we put the filter in the first place?
So
what are your thoughts on that?
So the case, it would be the reason for putting it in that case will be because they've already got some sort of embolus in place. So you're trying to prevent a more immediate, potentially hemodynamically compromising, life-threatening complication of pulmonary embolus. So in that context, again, I presume that wouldn't be an exclusive or a long-term situation. It would be a more hyperacute scenario, like for example, trauma or surgery, where you would need to accept a shorter window of time where you won't actually be anticoagulated, but with the overriding greater good of wanting to prevent pulmonary embolism. So again, that's a good question, but you've already got a pathology in place and undergoing one of these provoking events. So again, I think you would accept that risk, but know that you're actually doing good by the patient to prevent a pulmonary embolus.
That's great. I just have one final question for you. I get asked all the time. I've got someone who's got a PE and I can't anticoagulate them and I want to put in a filter. Now, my answer to that is generally, well, have they got symptoms of a DVT? No. So therefore, what are you achieving by putting in the filter? What is, are you happy to put in filters in people who have got PEs but no evidence of DVT?
No, and I think that contradicts the guideline as well. So again, you would want to, it's that principle of wanting it to act as a mechanical barrier. So you want it to barrier against something moving that you know is there. And it's that concept, especially in the trauma, that the SIR take that unless there is actually proven DVT, despite the risk of a PE or thrombus in trauma, they still advise against IVC filters. So I think you would use a similar rationale. It's like, unless there's definitively proven thrombus, acute thrombus within the lower limb, you would definitely want to avoid it. And again, it's more because of the complexities that can come with filter removal.
No, I completely agree. So what I've done there is I've just extended our time 5 minutes beyond known. We've got this little 5-minute window at the very end. I probably ought to leave it there. Honestly, I can't thank you enough. That was absolutely fascinating.
No, thanks for the opportunity.
I hope if you're happy to stay on and
of course,
and look at the questions that are in the Q&A box and answer them while the other talks are going on, I'd be incredibly grateful. So thank you.
No problem at all. Thanks again. Appreciate it. Cheerio.
Right, so moving on now, I'd like to introduce Dr. Peter Douglas. He's a vascular and consultant vascular and interventional radiologist based at the Queen Elizabeth here in Glasgow. And he's got a special interest in the imaging and treatment.
Guys, sorry, I'm about to do a presentation.
Oh. He's got a special interest in the imaging and treatment of systemic and portal venous disorders, particularly MR venography. So what Peter's going to be doing is looking at the use of MR in difficult venous thrombosis cases. So if I can hand over to you now, Peter, thank you very much.
Hi, thank you for that kind introduction. And sorry, I thought I was still muted when I was shouting at my colleagues to keep quiet, so apologies for that. So first of all, thank you for inviting me to speak on this topic, MR venography in DVT. Let's get stuck in. Oh, sorry, this seems to be an MR pulmonary angiogram. Now, the PIOPED 3 study described MR pulmonary angiography as not being very effective, but there are a number of centres in the world that routinely perform and offer MR pulmonary angiography for a selected group of patients, primarily younger females in the low to intermediate risk group, because it can be performed without using ionizing radiation. So in terms of reduction of breast dose to younger women, this can be an effective method to be used, but we don't do it here. So already this title has to change. It's MR venography in VTE, not just DVT. But focusing on DVT, it wouldn't be a radiology talk if we didn't mention the anatomy. So of course, we've already touched today on the difference between the superficial and the deep venous systems in the leg and the importance in distinguishing between them. Of course, we have the superficial veins in terms of the long saphenous and small saphenous vein, and of course the deep veins of the thigh. The nomenclature we use is the common femoral vein, the deep femoral vein or profunda femoris of the thigh, and then the popliteal vein, as well as the calf veins, and then the perforating vein. So a lot of different veins listed in there. Important to highlight, especially in reference to what was mentioned earlier, that the Terminologica Anatomica, the updated versions, there is no superficial femoral vein. It simply does not exist in the human body. The terminology is the femoral vein and the deep femoral vein, or the profunda femoris. And that is again for the very specific reason that was mentioned earlier. There are patients who have had an investigation confirming the presence of thrombosis in what was described as a superficial femoral vein, and these patients were not treated as DVT. Because it was felt to be superficial and not deep. So there is no superficial femoral vein. There is only the femoral vein, the common femoral vein, and the deep femoral vein of the thigh. Now, of course, this is the standard anatomy where coming up from below, the popliteal vein drains into the femoral vein, the confluence with the deep femoral vein or profunda femoris to form the common femoral vein, which then drains up into the pelvis. But that's just the most common anatomy. And of course, ultrasound, which is our main modality of imaging to confirm or disprove the presence of a deep venous thrombosis, is centered on imaging the common femoral vein, the femoral vein, and the popliteal vein, as well as, of course, the superficial vein, the saphenous vein, for the presence of a thrombophlebitis. However, there are a number of different anatomical configurations, and a group of French anatomists evaluated these and found that significant anatomical variants are present in about 12% of patients. And in reference to DVT, ultrasound may be limited in showing the extent of the true deep veins in about 8 to 9% of patients, simply because of their anatomy. And I'd like to highlight these two bitruncular configurations as they're known. So these patients have both a deep femoral vein, which is in direct communication to either the femoral vein or the popliteal vein. This is sometimes known as an axiofemoral trunk if the fusion is below the level of the adductor canal. If it's above the adductor canal, the anatomist called it a deep femoral and femoral configuration. I think the important thing to be aware of in these anatomical variants is that a duplex ultrasound could be performed. It could show normal compressible common femoral vein, and popliteal vein, and yet there could still be deep venous thrombus in the profunda vein, which is in direct communication and at risk of moving and causing a PE. And again, these configurations are about 4 or 5% of patients, so a significant subset. So what are the advantages of MRI over other imaging modalities? So first of all is the ability to do dynamic imaging. This is a sagittal T1 spin echo sequence through the shoulder of a patient. And we can repeat that after moving the patient without giving them any extra radiation. or any radiation at all, I should say. And we can see here that the subclavian vein is a lovely round circle as it passes between the clavicle and the first rib, but with the arm hyperabducted, we can see how compressed it becomes. And this is quite a effectively a normal appearance. If any one of us puts our arms hyperabducted above our heads, the vein will be partially compressed. But again, you can see how well we can assess this in cases of Paget-Schroeder or other types of upper limb DVT or thoracic outlet syndrome. Other advantages of MRI are, of course, its increased contrast resolution. Now, for the non-radiologist of you, what that means is it has a greater ability to distinguish between soft tissues than CT. So this is the same patient images just taken a few days apart, and on the screen left there's a CT with an arrow pointing to the iliac vein, and on the right is the MRI, and hopefully you can appreciate the difference. There is no way you can really determine whether or not there is any thrombus present in this vein, whereas in the MRI, it's relatively clear. This patient has had prior surgery and had an extensive lymph node dissection. So they had a very chronically swollen limb, but had had an exacerbation of their symptoms with worsening pain. So clinically, it was difficult to say whether this was an exacerbation of lymphedema secondary to lymphatic damage from surgery, or was there coexisting DVT? That was the clinical problem here. And a CT was performed to try and delineate that. And although you can see superficial venous collaterals, they were unable to confirm or refute the presence of DVT. You can see a little surgical clip here, which has caused a tiny bit of artifact on the MRI, but actually you can still see the filling defect quite clearly in the external iliac vein. And we performed further imaging down the leg in this patient, and you can also see there is contiguous thrombus through the femoral vein, the deep femoral vein, and actually in the deep veins of the calf. So this is the tibia and fibula, and we can trace the thrombus all the way down. So they had very, very extensive deep venous thrombosis, which was just invisible on CT. So how do we image? So I think the mainstay is through balanced, steady state free precession. Now, again, for those of you who aren't imagers, this may be a term you've never heard before, but it's incredibly simple and really common sequence. They're often used as localizers. So every MR scanner in the country can do this very easily. And this is the type of picture you get. This was taken yesterday. So we can see on the right, we can see we're at the level of the common femoral, so common femoral artery and common femoral vein, and see how large it is in comparison, as well as not quite circular, but rather ovoid. On the left, we have the common femoral vein, or just at the level of inguinal ligaments, maybe the tail of external iliac, and we can see the EIV or CFV with a linear filling defect in it. So this is either some chronic thrombus or synechia, whatever you want to call it. And the other sequence that we use, which is incredibly helpful, is post-contrast 3D T1 weighted gradient echo. Again, this is incredibly simple, straightforward, really old-fashioned sequences. Now, the two of these are not used very commonly in modern MRI protocols, and that's because MRI has advanced significantly. And if you want to do an MR brain or liver or pancreas, then there are a lot of fancier sequences that people prefer these days. They can give us extra information, but in terms of imaging veins, it's really straightforward. Go right back to basics, and again, every scanner in the country can do both of these pretty well. And the post-contrast 3D sequence, you can spend a little bit of time and achieve fantastic high resolution. So this is a 0.5 millimeter resolution 3D T1 after contrast from the knees to the ankles. And hopefully you can appreciate just the beautiful level of anatomical detail here. We can see all the fascia and the subcutaneous fat, the texture of the muscle, and actually the texture of the bone as well. So absolutely fantastic level of detail, which actually allows us to see right down to the level of individual valve leaflets in the deep veins below the knee. So when do we perform NR venography? Well, we actually do it all the time. So we perform as much MR arteriography as we can. So we try and direct all of our outpatient and some of our inpatient critical limb patients or claudicant patients who require some cross-sectional imaging. We try and direct them to MRI. And after our angiographic sequences, we add in these 3D T1 effectively venographic phase images where the contrast is distributed throughout the arteries and the veins. Although that allows us to see the arteries again in a little bit more detail, it also gives us crucial additional information, including the caliber and patency of the long saphenous vein, which is of course the main vein used for harvest by the vascular surgeons if they're going to do either a femoral popliteal or a popliteal distal bypass. Check the caliber, check for any branches, whether they've had previous interventions or venous stripping of this for varicose veins. And it allows us to give really detailed information to the surgeons to plan their operation. But it also can be used to show us thrombosis. Now, DVT is really underappreciated as a cause of claudication. And although this red box was highlighted to show the long saphenous vein, it was really just there to distract you from the presence of the contralateral DVT. So this patient was referred with right leg claudication, and they have no arterial disease whatsoever. Their claudication is venous claudication. And by the time they were imaged, they have very extensive DVT extending from below the knee, right up through the femoral popliteal segment, all the way to the common femoral vein. And one of my senior colleagues has performed an audit of this in our practice of our patients referred from our arterial groups from the vascular clinics. And depending on the cohort, whether it's patients with claudication or patients with critical limb ischemia, it's in the region of 5 to 10% of patients with arterial disease have either coincidental DVT or actually DVT as the etiology for their symptoms. And just as an example of that, a quick case discussion, a 42-year-old female presented having had acute onset of left calf swelling. She put up with that for a little while, and then it developed into severe rest pain before she presented to hospital. No obvious major risk factors for vascular disease. Had a normal left femoral pulse, but absent pulses distally, and clinically very poor perfusion to the left foot. Her right leg was normal to examination on her pulses. And which modality? So generally in a lot of the world, these patients would get a CT angiogram, but here we try to divert as many patients as we can to MRI. And this is a dynamic time-resolved MRI showing the arterial runoff below the knee and then the late venous filling. So you can see the blood flows into her right leg normally through the popliteal and then the infrapopliteal arteries. And on the left leg, there's basically no flow at all other than a network of irregular collaterals. And then you can see the late venous filling. And this is just a static image from the same appearance to show the difference between the two legs, completely absent arterial branches below the knee on the left leg. And this is an overview from her upper aorta all the way down. So normal aorta, iliacs, and femoral vessels with a complete abrupt occlusion at the level of the adductor canal all the way through her crural vessels. And when we look at her delayed or high resolution images from our post-contrast T1 spin echo, gradient echo, we can see the expanded deep veins in her calf filled with thrombus. And we can actually see a filling defect in the arteries as well as the deep veins adjacent to them. And that extends all the way up through the popliteal artery and the popliteal vein. And although the femoral artery was patent, the femoral vein was filled with thrombus right up to the level of the confluence where the common femoral vein was patent. So we can reconstruct that, and you can actually see in lovely detail the little dilations in the vein, the sinuses around the valves. You can see how they're all completely filled with thrombus. And we can delineate all of that all the way up and get fantastic, very accurate views right up to the femoral confluence there of the common femoral vein. And we believe that since this patient presented first of all with swelling and then a delayed presentation of pain, that she's actually had a paradoxical embolism where the thrombus has started off as a DVT, broken off, presumably gone through a PFO or other right to left shunt in the heart, and has ended up going back down her left leg, causing an arterial problem. So who to image of the DVT population. So in patients whom the deep veins are very deep, and this is the patient who we showed earlier. You see that his femoral vein is 11 centimeters below the skin surface, that the tissues are incredibly edematous, and ultrasound simply cannot penetrate through this to see the femoral vein very well. Also, the common femoral artery often lies over the top, and when it contains a lot of calcium, that steals away all of our ultrasound, and we can't get any penetration through that. But also, we want to, this is a relatively limited resource. We can't MRI all of these patients, so we would like to try and save it for when it really matters. I'm sure you're all aware that if ultrasound either gives a negative or an indeterminate result, in the majority of patients, they get anticoagulated and then a repeat examination in around a week's time. There may be cases where patients have either a very strong relative contraindication or an absolute contraindication to anticoagulation, in which case it would be critically important to know as soon as possible whether or not there is some thrombus there. And of course, the really difficult patients are the acute on chronics, where we know they have scarred veins. It's difficult, it may be very difficult to determine between the presence of old clot and fresh clot, and MRI can be really helpful with that. And here's a case to just to help delineate that. This is a different 42-year-old female. She's had multiple episodes of DVT, particularly in the last several months. They've been refractory to her medical therapy, and as I said before, the basis of imaging just really straightforward, balanced, steady state, free procession, really quick, easy sequence, just takes a few seconds, and we can see here the normal right common iliac artery and common iliac vein, whereas the left common iliac artery is been completely compressed by the overlying artery in a classic May-Turner or non-thrombotic vascular lesion. And as we follow that down, we can see that the left external iliac vein contains this chronic thrombus or synechia. Moving on to our 3D-T1, we can see that there is also chronic thrombus, not quite occlusive within the femoral vein, but we can also see that the patient has a hypertrophied profunda vein, deep vein of the thigh. So this is one of these patients who has an anatomical variant where they have the main drainage is through the deep femoral vein of the thigh rather than the femoral vein. And we can reconstruct this in whatever way we want to see that in addition to the chronic thrombus higher up, she also has foci of acute thrombus in the deep vein of the thigh at multiple levels, and this comes down in the axiofemoral trunk configuration to be contiguous with her popliteal vein. So far, those have all been examples of what's called indirect venography, where we inject contrast through an upper limb vein. We wait till it go around through the arterial circulation and the capillary beds before coming back up the veins in the lower leg and then the thigh. But we can also perform what's called direct venography, where we cannulate the affected limb. And this is a time resolved or dynamic venogram showing that. So I can put a venflon into the foot or distal calf in this patient, put tourniquets on the thigh to try and shunt all the contrast into the deep veins, because of course my cannula will have gone into a superficial vein, and that's not what we really want to image. And we can review each of these time points as a cross-sectional 3D volume to confirm that the contrast is preferentially draining up the femoral vein rather than either the saphenous or the profunda vein. So it's the femoral vein is providing the main deep venous drainage from the leg, and you can also see the chronic iliac stenosis and partial occlusion with very extensive collateralization and cross-filling, both across the pelvis and to abdominal wall collaterals here. MRI can also be used for follow-up of these complex patients who have really difficult disease, these mixture of difficult acutes or acute on chronics. And just an example of that, I was referred a case of a 50-year-old man. He'd had recent surgery for a hammer toe by the orthopedic surgeons, which was unfortunately complicated by severe infection. He developed very marked right leg swelling and tenderness over his deep veins, and DVT was confirmed by a positive duplex with thrombus extending up into the right iliac veins. So the top of the thrombus was not well delineated by ultrasound. Additionally, he then developed edema of the scrotum and his penis, which was felt to be extending DVT, which is extending proximally, and he had a new oxygen requirement. So initially he underwent a CTPA, which confirmed bilateral, moderate to large volume pulmonary embolism. And of course, he was commenced on anticoagulation. CT of his lower limbs was also performed, which again confirmed an expanded, acutely thrombosed common femoral vein, and this can be reconstructed to show complete full-length thrombosis of his femoral and popliteal veins all the way down. And we can see a tongue of thrombus here sticking up into the external iliac vein, which is obviously the source of his pulmonary embolism. Now, the vascular surgeons evaluated his leg, felt that it was particularly bad and towards the spectrum of phlegmasia, and I was asked whether or not I could offer anything to try and improve his leg. We considered thrombolysis of this, but due to the extremely large volume of thrombus, we thought we would attempt to perform a thrombectomy. So we used this device, which is from a company called Inari. The device is called a clot retriever. It has two components. One is a coring element, which scoops up the thrombus, and then a collecting bag, which allows it to deposit it there. And this is what it looks like being deployed. So you bring it, you would puncture from below popliteal vein, you pass it up through the thrombus in a collapse state before opening it out and then dragging it back down through the thrombus to collect it. This is the thrombus that we were able to remove from this man's leg. And these are some pictures of the venograms afterwards, showing pretty good, fairly brisk inline flow all the way up his popliteal vein and into his iliac veins. And if you just make a little mental note here, that the wire and the contrast filling the vein is actually very, very close to the femur. Although this says right, anatomically, this may look from anyone who's just to look at imaging like it was his left leg. That's because this procedure was performed prone, so we could puncture his popliteal vein. So the man was flipped and lying on his front. So we brought him back a few months later following anticoagulation for one of our indirect venograms to try and show if there was any residual or chronic thrombus. And unfortunately, this confirmed that there was a degree of residual subacute thrombus in his deep femoral vein. A couple of levels. However, the overall thrombus burden was hugely reduced. His symptoms were correspondingly reduced. I went to have a chat after him, and of course, although the treatment worked really well, the patient didn't like wearing his thromboembolic deterrent stockings, so just hadn't really been wearing them. So I kind of wagged my finger at him and told him he really needs to wear his TEDs, as well as continued movement and taking his anticoagulation. But what you may also notice is that this guy does not have thrombus in his femoral vein, but that his profunda vein is the main drainage pathway from his profunda. So again, he has an axofemoral trunk, and his femoral vein is really just a small collateral channel that isn't really providing the main drainage, but it's actually the profunda vein in continuity with the popliteal and axofemoral trunk. And although this is present on the CT, I just didn't appreciate it at the time. It's so much easier to see in MRI. Now, I do need to speak a little bit about alternative contrast agents. So this is a T1 weighted venographic sequence, really simple to acquire, but performed using ferromoxetol instead of gadolinium. Now, ferromoxetol is what's known as a super paramagnetic iron oxide, or SPIO. It does not contain any gadolinium, but is iron-based. It was originally developed as an iron replacement therapy, such as Ferinject or Ferriheme, but it was found to have very effective T1 shortening times. So is now used off license as a contrast agent in a number of centres. And I hope you can appreciate just the fantastic level of detail that we can get from ferumoxytol, and hopefully you can see some areas of some chronic thrombus and chronic occlusion, as well as the very extensive collateralization in this man. He was known to have complex disease, and this was used as a planning scan for a iliocaval reconstruction in a quaternary center. And the reason why ferumoxytol can be used so effectively for this is because it's iron-based. It's not excreted through the kidneys, but it's excreted through the reticular endothelial system. And that means that its half-life in the bloodstream is about 24 to 26 hours. So it's very, very long. So we can inject this. We can spend 4 or 5 minutes acquiring our sequences, and the contrast doesn't wash out. It stays there. In fact, this could be given on the ward or in an outpatient clinic, and we could bring the patient later that day or even the next day and get fantastic imaging.
Okay. Sorry to interrupt you, Peter. I'm probably going to have to stop you there just because we're getting quite short of time.
Okay.
I don't actually wait. There may be one question. Hang on, no. So there are no questions from the audience, but I just had one very, very quick question from you that I just wanted to check. You mentioned very clearly about these anatomical variants affecting about 12% of patients. Can you tell if someone's got that anatomical variant on a Doppler ultrasound? Or
I don't think so. As far as I'm concerned, I'll try and just share that previous slide then regarding that.
Because you said don't do MRIs in everyone. We can't do MRIs in everyone.
Well, absolutely, yeah, and therein lies the difficulty.
So therefore, I wonder, if you have a very high suspicion of a deep vein thrombosis and you don't see one, then you need to consider recourse to MRI.
I think that's right. I think that that's really critical, is that, as with everything, we can do a really fancy test, but that's only going to be helpful when it is encompassed with the appropriate clinical selection of those patients. So again, this is the diagram from before, and the area outlined in red is where duplex was going to focus. And I just don't think in our population of patients with swollen, tender legs and obesity that you can ever really see this clearly to say that we definitely don't have any of these ancillary communications. So I think what we need to do is, as you say, consider this in either refractory cases or these really difficult clinical conundrums, or sometimes the acute on chronics, the one that's just performed unexpectedly. And it should be a relatively straightforward thing to do once you have the protocol established. In many centres across the country where they haven't been doing this, it may cause a bit of a headache or a chin scratch, but we can share protocols between centres.
I would love to talk for absolutely ages, because I've just learned so much from you. So thank you so much for that. There have been 1 or 2 questions. I will have to move on, but there have been 1 or 2 questions in the chat and the Q&A. So if you're happy to just have a quick look at those, Peter, and if there's anything there that you feel you can answer, I'd be incredibly grateful. I'm just aware that we're pretty much going to cut off at 1 o'clock, so I need to just keep to time. But again, huge thanks from me and from Joe for a really interesting talk. Thank you. So now I have to move on to myself, which is a bit embarrassing. So I'll just share my screen. Okay, so the oh no, hang on, is it down here? Yeah. Joe, just bear with me. I'm just struggling with 2 screens here, so just bear with me a second. Wait a minute, I'm gonna just get rid of that a sec. I got myself very confused. No. Right.
Not only you want to try and email it to me.
Right, no, I'm
Oh,
getting
great,
there.
yeah,
I'm
it
just
looks like
pressing
it's
a lot
going
of buttons.
Perfect,
Can you see my
perfect.
screen?
Yes, just going to the,
Excellent. So it's going to the slideshow now.
yeah.
All good?
Yes, well done.
Excellent. Excuse me, I will get started. So thanks very much, everyone. I'm just rounding us off to give a little update on using direct oral anticoagulants or DOACs in cancer-associated VTE. And what I'm going to be talking about is a little bit of just the background of venous thrombosis in cancer. Go over, can you effectively and safely use DOACs? And if you can you do that in everyone who's got cancer? Then talk a little bit about how long you should be treating these patients for. And then I just want to touch very briefly on when you should be screening for cancer in patients who've got unprovoked venous thrombosis, because I think that's an area that still causes a little bit of consternation. So, so it's pretty common having a cancer diagnosis and associated with a thrombosis. And general rule of thumb, this isn't completely accurate, but general rule of thumb just to go away with is that about 10% of cancer patients will develop a venous thrombosis, and about 10% of patients with venous thrombosis will develop cancer within the year. These are people who have got idiopathic thrombosis. It's a really common cause of death. It's the second most common cause of death in hospitalized and ambulatory patients. And if you've got cancer and you get a venous thrombosis, it has a negative impact on quality of life, and it has a negative predictor. It's a negative predictor for survival. So, although I'm going to be mainly talking about DOACs, just to give you a bit of background on where we were before we could use DOACs in cancer. So we have known for years now, almost 20 years, that in the short term, low molecular heparin is much more effective than warfarin in patients who've got cancer. And this is due to the CLOT study. This was comparing dalteparin to warfarin. So you started with dalteparin and commenced warfarin, or you remained on dalteparin at therapeutic dose for the first 4 weeks, and then 75% therapeutic dose for the remainder of treatment. And it was very clear that the risk of recurrent venous thrombosis was much lower, although still on the higher side, much lower on dalteparin than it was on warfarin, and this was clinically significant. And this is why the Cochrane review in 2011, ages ago now, said, you know, the risk of recurrent venous thrombosis is much lower if you use dalteparin, although we just want to make it clear there's no difference in survival in these patients and there's no difference in bleeding rates. So for this reason, dalteparin has had a license to treat cancer-associated venous thrombosis for, you know, pretty much 15 years now. And because of the CLOT study, you have this therapeutic dose for the first 4 weeks and then 75% dose for the remainder of treatment. Tinzaparin then got a license of a few years later, with slightly weaker data, which I won't go into, but basically, although, you know, we would use whatever low molecular heparin is available in your health board, these are the two that actually have a license for cancer-associated venous thrombosis, just to give you a bit of background. So then, therefore, the question is, we know low molecular heparin is great, good evidence in dalteparin, not bad evidence in tinzaparin. If you're going to use DOACs, we need to know, are they effective, are they safe, and are they acceptable to patients? So what do we know? So we've now got some randomized controlled trials that have compared direct oral anticoagulants to low molecular heparin. I've listed them here. We've got the SELECT-D, which was UK-based. That's rivaroxaban against dalteparin. HOCUSI, international study, good patient numbers, edoxaban versus dalteparin. Then the Caravaggio trial, which was international, over 1,000 patients. And then the ADAM VTE trial, which was just USA-based with slightly less patients, but still quite a good number. And that was apixaban. And you can see all these studies are using dalteparin, and all of them use the CLOT regimen, i.e. therapeutic dose for the first 4 weeks, 75% afterwards. Follow-up for all these studies was 6 months, except the SELECT-D study that was a duration of 12 months. And these studies were very much looking at What's the rate of recurrence on anticoagulation? What's the rate of major bleeding? Now, this slide is really, really busy, and what I want to do is just highlight the important points. So what we've got along the top there is the Caravaggio, the Adam VTE, the Hokusai, and the Select-D study. So what was the rate of recurrent venous thrombosis when you compared the use of direct oral anticoagulants to dolteparin? There was the same rate of recurrence, saying in these randomized controlled trials that if you use direct oral anticoagulants, you are no more likely to have recurrent VTE than if you use lomlecroheparin. So far, so good. But major bleeding then was a little bit of a concern. So if you look particularly at the Hokusai and the Select-D data, there's an increased risk of major bleeding when you compare using edoxaban or rivaroxaban compared to dolteparin. This wasn't shown in the Caravaggio trial. So apixaban in that trial was not associated with increased risk of bleeding. We'll come on a bit more detail here, but it particularly looked at major GI bleeding. Now, although the Hokusai and Select-D study showed an increased risk of major bleeding, they didn't actually power or assess. So this is basically, God, I'm trying to think what NR means now, but basically they didn't assess it. It was assessed in the Caravaggio trial, and there's not an increased rate of major GI bleeding. With clinically relevant bleeding, again, there was an alert this time just with the rivaroxaban study, but there wasn't an increased risk of clinically relevant non-major bleeding in the other studies. So summarizing all of that then, so the Hokusai and the Select-D study did show an increased risk of major bleeding. And although they didn't actually analyze the data, as in give it any statistical significance, the people who were having major bleeding it was GI major bleeding, and it was an association with GI cancers in the majority of cases. With the Select-D increased risk of clinically relevant non-major bleeding, the alert there was actually genitourinary bleeding. But these similar alerts were not seen in the Caravaggio trial, which was with apixaban. So therefore, taking all that in mind, can DOACs be safely used in all cancer patients? Perhaps we should be avoiding them if patients have got a GI or a GU malignancy, or should you be using apixaban if you have those malignancies? Perhaps it's safe to use that. One thing we really have to consider, though, is who was in these trials. The exclusion criteria in all of the trials was, don't go into the trial if you're at high risk of bleeding. So people who the clinician thought, I don't think I'm going to put you in this trial because I think you're high risk of bleeding, you're not exposing those people to a DOAC. And I think we need to bear that in mind. If the patient had a very poor clinical state, so an ECOG of more than 2, they were also excluded in most of these, if not all of these trials. If you had severe liver disease, if you have poor renal function, and if you're on some of the potent inhibitors and inducers of DOAC metabolism. So although the clinical trials of DOACs seem to show something really great, the possible increased risk of bleeding, a lot of the patients out there with cancer probably weren't enrolled in these trials. We have to bear that in mind. And when we talk about these drug interactions, these inducing inhibitors of metabolism, there's a lot of cancer medication, so sort of your systemic anti-cancer therapy that involves induces and inhibitors of DOAC metabolism. So this really has to be borne in mind. So are DOACs a good treatment option for patients with cancer? Yes, I think they are. I think they are effective. They're I think we've definitely shown they're effective. I think we've shown they're generally safe with some of those providers I've said about who is excluded. But there's really some unanswered questions. What is their interaction with chemotherapy? What is the effect of vomiting and diarrhea? So we're thinking this is absolutely great. We've got drugs we can give that we don't have to inject the patients. But patients often have poor absorption of oral medication when they're on a systemic anti-cancer treatment. They may be vomiting, they may have diarrhea. Things where you've got to be concerned, are they going to absorb their direct oral anticoagulants? Lomlecroheparin has a shorter half-life than a DOAC. Therefore, we've got to be very careful about the timing of dosing of DOACs prior to any invasive procedures, which are very common in cancer patients. And we have quite good guidelines about a safe platelet count for lomlecroheparin. Is that safe platelet count relevant for direct oral anticoagulants? So there's things that just have to be considered. And hot off the press, excuse me, the British Society of Haematology guideline for the diagnosis and management of cancer-associated thrombosis was literally published last week. You can find it online at the reference I've given you below. This is what I think a really helpful algorithm for can you use a DOAC, can you not, which I hope will really help people going forward. So if the site of cancer is in a place where the trials seem to give an alert of bleeding, so gastrointestinal, urothelial, and then possibly intracranial, where you really are worried about the increased risk of bleeding, perhaps you don't want to use a DOAC. If you've got issues with GI tract impairment, and this may be temporary or it may be permanent, perhaps you shouldn't use a DOAC. Severe renal impairment, don't use a DOAC. Strong drug-to-drug interactions, don't use a DOAC. And then also patient choice. Now, you know, most people are probably going to choose an oral medication, but you need to find out from them if that's definitely the case. So I think this is very useful that, you know, I think I do want to say with this talk, we can use DOACs in cancer patients, but just step back for a moment and think, is it definitely okay for the cancer patient I'm looking after? And I'll come on to what we do about duration of anticoagulation in a moment. On the next slide, in fact. So now I apologize that my slides have not quite fitted, but basically this is how long should we be treating patients with cancer with anticoagulation for if they've had a venous thrombosis. Now we know quite clearly that if a patient doesn't have cancer, you're going to give 3 to 6 months of anticoagulation, and then we will continue anticoagulation if there's a persistent risk factor or the patient's had an unprovoked venous thrombosis. That's the general rule of thumb. Now, the trials to date in cancer patients, whether that be low molecular weight heparin, whether it be direct oral anticoagulants, has usually only been 6 months. As I showed you, the SELECT-D went up to 12 months. But is 6 to 12 months of anticoagulation for a cancer patient enough? Well, the consensus has really been out there now for years, I would say, that cancer is a persistent risk factor. So if a patient has active cancer, or they're receiving active treatment for that cancer, chemotherapy, radiotherapy, so and/or, then you should carry on anticoagulation. Always remembering, particularly in the cancer population, the status of the patient. So, okay, we think we should carry on anticoagulation for the long term, but what is the bleeding risk of the patient currently? What is their quality of life? What's their life expectancy? And this obviously always has to be discussed with the patient. So if we're saying the consensus is, yes, we need to carry on for the long term in patients, or patients who still have active cancer or on treatment, what do we use? We've really got no evidence here at all. So, you know, we don't know whether you should use low-molecular heparin, whether you should use warfarin. We'll come on a little bit to the direct oral anticoagulants in a moment, where it's, again, we really don't have that much information. But okay, if you say to a patient, well, we could use low-molecular heparin, there's a cost involved, there's daily injections, but if the patient's been on low molecular heparin, perhaps they feel familiar with it and there's minimal side effects. Warfarin, I think most of us probably wouldn't use this, but you know, if people are trying to go from a low molecular heparin to an oral medication, you know, the problems, similar to some of the problems I've brought up with the direct oral anticoagulants, can interact with chemotherapy, GI symptoms, vomiting, diarrhea, etc. But again, it is oral. So seeing as we have good evidence that direct oral anticoagulants can be effective for treating cancer-associated thrombosis in many cancer patients, perhaps direct oral anticoagulants are the one for us to look at going forward. What evidence do we have? Not much yet. This is the only study that has given us any evidence at all, but it's poor evidence. So this is basically a single-arm study of apixaban. So basically what they did in this study was they just looked at patients who had cancer who got 5 milligrams twice a day, the standard dose for apixaban for the first 6 months, and then carried on 2.5 milligrams twice a day, the recognized secondary preventative dose. So it's single arm, 300 patients, all types of cancer and all types of venous thrombosis are included. I think what's quite interesting is that you can, this is showing recurrent venous thrombosis and major bleeding. In that first 6 months, the risk of recurrent venous thrombosis and the risk of major bleeding is higher. And as time goes on, the risk of recurrent VTE and the risk of major bleeding falls off. So I think what's quite reassuring here is it does seem that you are improving the risk of recurrence and the risk of major bleeding, as it seems to be reducing over time. But obviously there's been no placebo arm, there's been no comparator arm with different dosing. And that's the only data we have to date. However, we do have some clinical trials around the corner that hopefully will report relatively soon. We've got the EVE trial, which is just US based. 370 patients need to be randomized, and they'll be randomized between apixaban 2.5 BD versus 5 milligrams BD, and they're going to be followed up for still only for 1 year, but 1 year after they've completed their first 6 months of treatment. Having looked at Clinical Gov's website just a couple of days ago, 200 patients have now completed that study to date. The APICAT trial, which we're all really waiting for, this is international, almost 2,000 patients, again, comparing apixaban at the 2 different doses that we currently use in non-cancer patients, again, follow up for a year. They've now recruited over 1,600, according to the last update on the Clinical Trial Gov website. And I'm not surprised these trials have been done using apixaban. Apixaban seems to be giving the least alert in terms of bleeding risk. It will be so very interesting when these results come out, because perhaps then we can either say, actually, yes, apixaban works, but we need to use the higher dose of 5 milligrams BD compared to the non-cancer population, or maybe 2.5 twice a day will be effective. Just watch this space. But I think we're going to watch this space for at least another 18 months. So what do we do now while we wait for those 18 months? I think if someone has got active cancer and/or they've got ongoing systemic anti-cancer therapy, we need to continue anticoagulation. Otherwise, their risk of thrombosis is high because they've got a persistent risk factor. My personal opinion, and this is what I do in my own practice, is I carry them on with the apixaban 5 milligrams BD with all the provisos I've talked about before. You know, can they tolerate it? They're not vomiting, diarrhea, etc., etc. But as I've said, you've got to balance the bleeding risk. What's the bleeding risk? What's their cancer status? What's their overall health, quality of life, life expectancy, and patient preference? Just one thing I wanted to touch on. I'm so sorry, my titles have gone off the top of the slides. One thing I just want to touch on is what I often get asked this through phone calls. What do you do if you have a recurrent thrombosis despite anticoagulation? And you may have noticed when I was going through some of the data that despite anticoagulation, there is still a high risk of recurrence on anticoagulation. So warfarin, you know, the rate was sort of 15%, even on low molecular heparin and direct oral anticoagulants. You're looking at a recurrence rate of somewhere between 5 and 10%. So recurrences will happen on anticoagulation. Now, if they happen off anticoagulation, fine. Just use a direct oral anticoagulant or low molecular heparin. If you have a recurrence on anticoagulation, I suspect the next thing wouldn't happen very often, but recurrence on anticoagulation and you're on warfarin, go to low molecular heparin. If you're on a direct oral anticoagulant or low molecular heparin, then you can't use a DOAC anymore, but increase your dose of low molecular heparin by 20 to 25%. And if, despite doing that, you have a further recurrence, then you have 2 options. You could move to twice daily dosing, where you're going to get higher anti-10A troughs, but not as high peaks. And again, I apologize that my slides have got a little bit warped, but basically if you're on twice daily dosing, you do want to measure anti-10A levels, and you want to aim for a level around about 0.8 to 1 anti-10A level. Or you may decide, after having increased the low molecular heparin dose by 20 to 25% at the time of first recurrence, is that this next recurrence, you will keep them on once daily dosing to get your troughs won't be that much higher, but your peaks will be a lot higher, and then go for an anti-10A level of between 1.6 to 2. The evidence base for this is poor, but basically what everyone is thinking is, I've given a certain level of anticoagulation, it hasn't worked, I need to give more anticoagulation. So the final bit of my talk is just to reiterate about what we do with patients who present with an idiopathic and unprovoked venous thrombosis. We've got this, oh my God, there's a 10% risk they're going to have cancer in the next year. What should I do? So what is really clear from a study that was done now in the New England Journal of Medicine almost 10 years ago now, is that extensive screening of a patient does not alter time to diagnose a malignancy nor add mortality benefit. That was shown very, very clearly in a randomized control study from Canada 10 years ago. And what should happen is investigations should be symptom directed. So everyone should have a full history a full physical examination, basic laboratory testing. By that, I mean a full blood count, renal function, liver function. They should all have a chest X-ray. They should all have their urine screened, basically looking for bloods, and also be having age-appropriate cancer screening. Now, in this country, everyone is screened for breast, cervical, and bowel. We don't do prostate screening yet for the general population, but I think there's a general feeling now that, okay, you've had an idiopathic venous thrombosis, you're of a certain age, perhaps we should be checking PSAs as well. And this will pick up cancers. This regimen that I've just outlined there will pick up cancers just as well as if you put patients through a whole body CT scan with various complicated tests to particularly look at their pancreas. The Canadians did some really, really complicated imaging in comparison to these basic things I've described, and it showed no benefit in outcome at all. Now, just some provisos though to what I've just said. Okay, if you've got someone who's had venous thrombosis despite being on anticoagulation, then your threshold for looking for cancer is higher. Same if you have a recurrent venous thrombosis in a very short time frame. You present with bilateral DVTs, you present with a very high D-dimer. Now, I've written there 5,000, but you know, that's not a, yes, if it's 4,450, you don't need to be worried about cancer. It's just to say it needs to be strongly up, okay, then be concerned. And then, as was mentioned in Rob's talk, if you have a hepatic or portal vein thrombosis, you need to be thinking, has this patient got abdominal cancer? So then, again, it's still doing targeted investigations, but it's not the whole general population of anyone presenting with an unprovoked venous thrombosis. So in summary, and I hope I kept to time. I hope I kept to time. I just want to say that when you meet a patient who's got a cancer-associated thrombosis, you probably can use a direct oral anticoagulant, and you probably can use it safely and effectively. And that applies to many, many patients with cancer-associated thrombosis. But there is some caution. Has the patient got a GI or a GU cancer? Have they got poor renal function? What about drug-to-drug interactions? And for a lot of these patients, you may want to be liaising with a pharmacist, a cancer-related pharmacist, to make sure that you can safely use a direct oral anticoagulant. Therapeutic dose direct oral anticoagulation can be continued for greater than 6 months, and I would recommend we do that until we know the results of the EVE and the APICAT study. And my final thought is, don't put everyone with a venous thrombosis through the CT scanner. It's not required. So thank you very much. And I'll have to see if there's any questions there. I realise we're just a little bit over time. I just need to stop sharing my screen. So just bear with me a second. Talking and sharing is just proving just that slightly bit challenging. Right. I just want to stop sharing. How do I stop sharing? I can see how to share, but not how to stop sharing.
The same button should have stop sharing.
Yeah, I would have thought so. And it only says share on it. So it's the same button. And why is that not advanced? What's this do? Well, I can talk while my screen's still there. I'll just see if there's any questions, because I realise we've gone a little bit over time. Okay, I'll take it. A lot of people have said thank you, so thank you very much. So we will need to finish now because we're 5 minutes over time. And I'm sorry, I just need to go in the Q&A. I just want to make sure I don't miss anything drastic. Right, what's the consensus about dose of DOACs in cat with persistent cancer or non-cubical cancer beyond 6 months, beyond 12 months? Hopefully I've answered that question. Basically, at the moment, I would say use therapeutic dose direct anticoagulants ongoing until it's not in the patient's benefit to do so. And I'm not aware of a study looking into lower doses of edoxaban beyond the 6 months. And that's a very good point, though, because it has less drug interactions. Someone else has asked, any thoughts on DOACs in cat for low body weight? I think you're really going to have to look at bleeding risk there, because you might be concerned that if the patient is small, because obviously we have caution with patients over under 50 kilograms if they don't have cancer. I think you'd want to be really cautious about using that, because probably the bleeding risk in a cancer patient could well be a little bit higher than it is in a non-cancer patient. So you might want to consider avoiding. It's not a definite cutoff, but you might want to consider avoiding. And someone's asked me, I'll just quickly answer this, treatment of CVC related, so catheter related, central catheter related venous thrombosis. Yes, they need to be anticoagulated. They need to either be anticoagulated for 3 months or for as long as the catheter remains in, whatever is the longest. So I hope that answers that question. What I now need to do, despite the fact I'm still sharing my screen, I apologise for that, is to really, truly thank all the speakers. They've been all of tremendously high calibre. And I have to say that I've learned loads myself. So thank you to everyone for attending. Please do carry on attending the rest of the meeting. And I wish you all a very good rest of day. Thank you very much.